Artificial intelligence doctor. User question. What is the impact of autonomic nervous system tone, sympathetic versus parasympathetic dominance, on the type and severity of arrhythmia observed during pacemaker LOC at varying bradycardic heart rates, 40, 30, 27 BPM, and could modulation of this tone be a therapeutic target? Claude AI answer. The autonomic nervous system profoundly influences arrhythmogenesis during pacemaker loss of capture, LOC, with the balance between sympathetic and parasympathetic tone creating distinct arrhythmic substrates at different bradycardic rates. Autonomic influence on arrhythmia type and severity. Sympathetic dominance. At moderate bradycardia, 40 BPM, heightened sympathetic tone increases automaticity in subsidiary pacemakers and enhances triggered activity through delayed afterdepolarizations. This creates a substrate for ventricular ectopy, accelerated idioventricular rhythms, and potentially ventricular tachycardia. The increased intracellular calcium cycling under catecholamine stress makes the myocardium more susceptible to both early and delayed afterdepolarizations. At severe bradycardia, 30 to 27 BPM, sympathetic stimulation paradoxically increases arrhythmic risk despite the compensatory intent. The combination of prolonged diastolic intervals and enhanced automaticity creates conditions for both escape rhythm competition and triggered arrhythmias. The QT prolongation associated with bradycardia, combined with sympathetic stimulation, significantly increases torsades de pointes risk. Parasympathetic dominance. Under vagal predominance, the primary concern shifts to conduction abnormalities and enhanced automaticity suppression. At 40 BPM, high vagal tone may further suppress subsidiary pacemakers, leading to more profound pauses and increasing dependence on lower escape rhythms. The shortened refractory periods associated with vagal stimulation can facilitate reentrant circuits if conduction heterogeneity exists. At 30 to 27 BPM with parasympathetic dominance, the risk profile includes prolonged asystolic pauses, junctional escape rhythms with potential for AV dissociation, and paradoxically, atrial fibrillation due to shortened atrial refractoriness combined with the stretch-induced triggers from bradycardia-related volume loading. Rate-dependent mechanisms. The specific heart rate during LOC determines the interplay between autonomic tone and arrhythmic substrate. 40 BPM represents mild hemodynamic compromise where autonomic responses are compensatory but can become maladaptive. 30 BPM crosses the threshold where cerebral perfusion becomes compromised, triggering more aggressive sympathetic responses. 27 BPM approaches the critical rate where even brief pauses can cause syncope, creating a vicious cycle of autonomic instability. Therapeutic implications. Sympathetic modulation. Beta blockade during pacemaker LOC presents a complex risk-benefit scenario. While it may reduce triggered arrhythmias and sudden death risk, it could worsen bradycardia-induced hemodynamic compromise. Selective beta 1 blockade might preserve some chronotropic response while reducing arrhythmic risk. Parasympathetic modulation. Anticholinergic agents like atropine can temporarily improve heart rate during LOC, but may unmask underlying conduction disease and increase atrial arrhythmia risk. The effect is often transient and may not address the underlying pacemaker malfunction. Novel approaches. Cardiac sympathetic denervation has shown promise in refractory ventricular arrhythmias and might be considered in patients with recurrent LOC and sympathetically mediated arrhythmias. Vagal nerve stimulation, conversely, might benefit patients with sympathetic predominant arrhythmic storms. Pharmacological considerations. Class 1 antiarrhythmics are generally contraindicated due to their negative chronotropic effects. Class 3 agents carry torsades risk in the setting of bradycardia-induced QT prolongation. Magnesium supplementation and correction of electrolyte abnormalities become critical as bradycardia-induced cellular changes can exacerbate hypokalemia and hypomagnesemia effects. Clinical integration. The most promising therapeutic approach involves real-time autonomic monitoring through heart rate variability analysis, allowing for personalized autonomic modulation strategies. Temporary pacing remains the definitive acute treatment, but understanding autonomic contributions can guide both immediate management and long-term device programming strategies. The concept of autonomic pacing. Adjusting pacemaker parameters based on autonomic tone represents an emerging frontier that could minimize LOC-related arrhythmic complications while optimizing hemodynamic support.